immunology session, and right after that, we are going to be having, um, our assessment right after 2 to 3 hours after the session. So, as you guys know that we have did immunology session, I revised it again. Dr. Moaz did it once. So today I'm going to do some selective topics from the high yield one side. So I'll do 4 to 5 of the selective topics in a big detail, and I'll just try to wind up this session today. Okay, by starting with some high yield. So I would just let you guys know that which topic should I start first. Hello, vaccines. Okay. Okay. What else? So vaccines are going to be my first topic. What should be the next topic? What do you guys think? Just give me some high yield topics which you guys are facing difficulty with. So I'll be starting with that first, right? Anyone else? Hypersensitivities. Okay, that's the second one.
Sir,
Transplant
important
rejection.
cytokines.
Cytokines. Okay, that's the fourth one. So transplant. Okay. Cytokines. What's the last one? You guys want me to do
And sir,
first?
antibody structure.
Antibody structures. Okay. So first of all, let's start with our hypersensitivities, right? Hypersensitivity is going to be the first one. The second one, we are going to discuss the vaccination and transplant. Okay. So both of them are like, all of them are okay. So hypersensitivity. So we are going to start from this one, type 1 hypersensitivity, right? So first of all, you guys should know what is type 1 hypersensitivity. All of you guys have the idea of type 1 hypersensitivity, that it's basically mast cell degranulation, right? That's whenever like type 1 hypersensitivity come, the first thing which should just come in your mind is mast cell degranulation, right? So first of all, you should know that how does the mast cell degranulates and what's the immediate effect and the late effect, right? That's also really important. So remember, let's just take an example of asthma, right? Is basically an example of type 1 hypersensitivity. For example, whenever we have first exposure to a to an allergen, what would happen first? Okay, remember. First of all, we are going to the antigen presenting cells are going to take that, right? The antigen presenting cells are going to present them to CD4 helper T cells, right? Are you guys following me? Hello?
Yes, yes, sir. Yes,
Okay,
sir.
that's great. That's great. Okay. So the antigen presenting cells are going to take that. They're going to present it to CD4 positive T cells. We know that. CD4 positive T cells further have two fates, Th1 or Th2. We know that, right? Th1 response is going to give us macrophages, while Th2 response is going to activate our B cell response, right? B cell response. Okay. So can you guys just tell me asthma is an example of Th1 or Th2? What do you guys think? It would be Th1 or it would be
TH2.
Th2? Th2. Th2. Why? Because for the sensitization of mast cells, we need IgE to be there, right? And IgE is an antibody which comes from your B cells. It means that in asthma, first of all, we are going to be having Th2 response, right? And that Th2 response is going to give us IgE. Once we have IgE, what would happen? These IgE are going to go, they're going to sit on the surface of your mast cells, right? They're going to sit on the surface of mast cells. That's what we call mast cell sensitization, right? Mast cells are going to be sensitized. If an individual is and all of the allergen is basically going to push these IgE towards one another. They're going to aggregate this IgE, right? Like IgE can consider to be like handles upon the surface of mast cells. If I'm just pulling all of those handles to one towards one another, so what happened as a result of that, your mast cell is going to degranulate. Mast cell is going to you know release whatever is present inside that. So that's basically going to be called as mast cell degranulation. What do we have inside the mast cell? We have histamines. We know that, right? So histamines are going to be released. Tryptase is also going to be released, right? And some glucotrienes. So we have two kinds of effects. The immediate effect, which occurs in minutes, and the late effect, which occurs after hours. That's really important to know. Really important, right? So, like you guys are going to be having a UWorld MCQ related to it as well, which is basically going to ask you the lead effects of type 1 hypersensitivity, right? So, as the mast cell degranulate, we are going to be having tryptase release into the serum as well, right? This serum tryptase basically show you it's a marker for mast cell activation. Keep that in mind, right? The tryptase is basically a marker of our mast cell activation. That's very important. What are the late manifestation? What are the late manifestation of type 1 hypersensitivity? We are going to be having like chemokines, eosinophils also being released, right? So the eosinophils are going to be the late manifestation, right? So in the late, basically the arachidonic acid pathway is going to be activated. Okay, it's going to give us a lot of chemokines, eosinophils, and eosinophils in turn is going to cause inflammation and tissue damage by something called major basic protein, right? So eosinophils basically contain something called major basic protein, which basically causes damage. When do we see eosinophilia? We know that whenever we have any kind of parasitic infection, we are going to be having eosinophilia, and besides that, we can have eosinophilia in allergic reactions, right? So since asthma is type 1 hypersensitivity, that's an allergic condition. So obviously we are going to see eosinophils here, okay? So the first type and the second type, anaphylaxis. We know histamine itself is a vasodilator. So whenever we have a lot of, release of a lot of histamines from these mast cells, so it can lead to anaphylactic shock as well. You know what is anaphylactic shock? Whenever we have extreme vasodilation, so due to that vasodilation, we do not have proper pressure within the blood vessels to perfuse the organs, right? So whenever the organ perfusion is affected, that's basically called what? That's called shock, right? And as it's due to anaphylaxis, right? Yeah, due to vasodilation, so that's basically going to be called as anaphylactic shock. Is it clear? Do you have any questions in type 1 hypersensitivity?
No, doctor.
Oh, that's great. Let's discuss type 2 hypersensitivity. So keep one thing in mind. Type 2 hypersensitivity is seen whenever, okay, if you guys remember something of complement system, right? We discussed different pathways of complement system. How can we activate complement system? We discussed that we have, our classical pathway. To classical pathway, how do we activate the complement system? Via the help of IgG and IgM, remember? Then we have alternative pathway, lectin binding mannose pathway. Did you guys remember all of these three pathways?
Yes.
Hello? Okay. So one of which was your one of among these three were your classical pathway. So in the classical pathway, we discussed that whenever we have any kind of bug or anything, first of all, your antibodies are gonna go. They're gonna sit there. Okay, which antibodies, IgG or IgM, and they're gonna activate your complement system. Complement system is going to form the membrane attack complex, and this membrane attack complex can then lead to destruction of your of your bug, for example, or anything, right? So you can somehow relate that was your type 2 hypersensitivity. Whenever your antibodies go, they sit on the surface of an antigen, right? So antigen can be either a bug or sometimes your own body blood cell, like the red blood cells, can be your antigen sometime, right? Leading to autoimmune hemolytic anemia. We are going to be discussing it, right? So in type 2 hypersensitivity, the antibodies are going to go directly. They're going to sit on the surface of antigen, and your antibodies can do two things. Either it can call the complement system to come and destroy a bug or an antigen, or either it would just tell your natural killer cells to come and destroy an antigen, right? That's the two, fates of your antibodies, which it can do, right? So whenever your antigen, your antibody is basically calling your complement system, that was basically a classical pathway, right? In classical pathway, we discussed that IgG, IgM, they can, activate the complement system, right? So that's basically an example of type 2. Whenever the antibodies are going, they're sitting against, the antigen inside our body can be anything. It can be receptors, right? Sometimes. So that's basically a type 2 hypersensitivity, okay? Okay, so the complement is going to cause a destruction, it's going to cause inflammation. You guys can see it here. But another thing, it's not only about the type in type 2 hypersensitivity we are going to be have destruction. That's not always the case, right? Sometimes the antibodies can go, they can attach against a receptor, and sometimes it can increase the activity of receptors, or either it can decrease the activity of receptors. That's really important to know, right? That's really important to know. Like, for example, we have a disease called Graves' disease, right? What happened in Graves' disease, if you remember, we are going to be having auto antibodies. And what these auto antibodies were doing, that were basically attaching to the surface of your TSH receptors, and they were increasing the activity of these receptors. And that was an example of type 2 hypersensitivity. So in type 2 hypersensitivity, we would not always see destruction, right? We can see three things: either destruction, either increase activity of the receptor, or either decrease activity of the receptor. So let's take an example of decreasing activity of a receptor. Myasthenia gravis. We discuss in myasthenia gravis, we are going to be having antibodies that they're going to sit against the acetylcholine receptor. And once they sit against the acetylcholine receptor, now the acetylcholine cannot work on the receptor because it have blocked the activity of receptor. That's also an example of type 2 hypersensitivity. So whenever you see type 2 hypersensitivity, you should just keep three to four things in mind. They are antibodies against any receptors, any antigen. Okay, what's the goal of these antibodies? They can do three things. Either they can cause destruction. How do they cause destruction? They can call upon the complement system. They can call upon the natural killer cells. Okay. What else? It can increase the activity of receptor. What's the example of that? That's Graves' disease. It can decrease the activity of a receptor. The example for which is myasthenia gravis. Is it clear? So we have something called direct Kuhn test and indirect Kuhn test, right? So the goal of both of these tests are to detect antibodies in your serum either, or antibodies directly bonded to your red blood cells, right? So we discussed something called autoimmune hemolytic anemia. Yesterday, did you guys do the autoimmune hemolytic anemia? Hello?
Yeah, that was analytical anemia.
Okay. So in autoimmune hemolytic anemia, basically what's gonna happen? We have antibodies against the red blood cell. And once we have those antibodies against the red blood cell, that's going to lead to destruction, right? So we have two variants of that, either the cold one or the warm one, right? In the warm one, we are going to be having like IgG, it's an extravascular, and the warm, the cold one basically includes Ig, and we are going to be doing that in detail in our hematology section, right? But you should remember something called Coombs test, direct Coombs test, and indirect Coombs test. So in direct Coombs test, we look for the antibodies which are directly attached to the red blood cell surface. Antibodies, if directly attached to the red blood cell surface, we detect it with direct Coombs test. So what do we do in direct Coombs test? We take an individual blood vessels, red blood cells. We add anti-IgG antibodies, right? If there are some antibodies against the red blood cells, so you are going to have agglutination. So agglutination basically would suggest that yes, against these red blood cells, we have antibodies on the surface of them. That's direct Kuhn test. In the indirect Kuhn test, we are looking for the antibodies in the serum. So what do we do in that? We take the patient's serum, we add some red blood cells into that, and once we add some red blood cells into that, okay, if the patient serum have antibodies in case of autoimmune, obviously those antibodies are going to attach with the red blood cells which I'm adding, right? And again, if I add anti-IgG, if we have agglutination, it would confirm that yes, the serum contain antibodies. We are going to do it in our hematology section in detail, but till now you should also only know that in direct Kuhn test, we look for the antibodies against the red blood cells. In indirect Kuhn test, we look for the antibodies, in the serum, right? That's all. So this was your type 2 hypersensitivity. Do you guys have any questions related to type 2 hypersensitivity?
No.
Okay, great. So these transplant reactions and everything, we are going to do it there, right? So let's wait for that. Then we have our type 3 hypersensitivity, really important. Okay, how to memorize or relate the examples. Okay, so it's all about concept, right? Once you are doing myasthenia gravis in the MSK section, you will better have understanding of this disease. Graves' disease was basically done in it's a topic of your endocrinology, so you should be having an idea of that, but you only have to integrate. We did Ghost-Pasteur syndrome, if you guys remember, in our renal section, right? Hemoptysis, hematuria. Remember that was an example of type 2 hypersensitivity that I just told you, right? Hyperacute transplant rejection. We are going to do it in a bit, right? Rheumatic fever is going to be a topic of your MSK. Hemolytic disease of newborn is going to be a topic of your currently which we are doing red blood cells, right? Okay, transfusion reaction, we are going to do that. Immune thrombocytopenia, it was a topic of your platelets, So all of and all, you don't have to memorize it here. You must know the entire details of this pathology. Once you know that, okay, we did immune thrombocytopenia, right? We did like 2 days back. You guys remember what was happening in immune thrombocytopenia? I just told you that your spleen is going to make antibodies against your platelets, and your spleen then is going to destroy this complex, remember, which is going to lead to thrombocytopenia. Whenever we have thrombocytopenia, you're going to be having superficial skin bleed or mucosal bleed. So you can see if antibodies are directly attaching to the to the platelets, and then we have platelets destruction. So we did this discuss in type 2 hypersensitivity. Antibodies directly attaches to cell surface, right? The antigen in this case is your platelets. That's all. That's your type 2 hypersensitivity, right? Is it clear? Hello? Okay. So let's just come down to our type 3 hypersensitivity. We discussed what is type 3 hypersensitivity. So sometimes you can have something called antigen antibody complexes, right? Like antigen can enter into your body. It can okay. It can be any kind of antigen, right? It can be self antigen. Your body can sometimes in SLE we are going to discuss that. So antibodies, whenever binded to antigen, collectively they are called as antigen antibody complexes, right? Is that clear? Hello.
Yes.
Yes.
Okay.
Yes, sir.
Antigen and antibodies, whenever they are bounded to one another, they're basically called immune complexes. It's basically the goal of your complement system to destroy them. That's really important, right? That's really important. Okay. So keep one thing in mind. Whenever the immune complexes, build inside your body, inside your blood, and it's to certain high extent that what these immune complexes are going to do, they're going to deposit in different tissues. Okay, so sometimes you can have a lot of immune complexes, that immune complexes can basically deposit in in different tissues. For example, they can deposit in the in your kidney basement membrane. They can deposit in the skin. In SLE we have seen that, right? So what happens? It's the goal of your complement system to destroy these immune complexes. So whenever they're deposited in the tissues, they're going to activate the local complement system. They're going to activate the local tissue complement system in order to destroy these immune complexes. But in attempt of destroying these immune complexes, the complement system basically destroy your own body tissues as well, right? That's the main thing. That's the main theme you should just keep in mind. Okay, so it's basically an example of type 3 hypersensitivity. So whenever we have immune complexes, it rises in number, it would deposit in different tissue. They're going to activate your complement system, your local complement system, and that local complement system, along with clearing these immune complexes, are going to lead to destruction of your tissues, right? That's your type 3 hypersensitivity, right? We know that the complement system have a lot of, we discussed that in detail, right? Okay, so in the complement system, what's the thing which attract neutrophils? Yes, you guys better know that.
C5A.
That's C,
C5A.
C5A.
C5A, right? C5. So that would attract the neutrophils. So we have option in C3B, right? C3B was your option, right? That can also
LIG.
attract. Yes. Okay. That can attract a lot of things, and it can lead to destruction of these immune complexes along with your tissue. So you're having a lot of damage. That's a type 3 hypersensitivity, right? Okay. So in type 3 hypersensitivity, we can have something called serum sickness. Like it's a generalized term which is seen in most of condition which includes type 3 hypersensitivity, serum sickness, right? Serum sickness. So what happens in these serum sickness? These antibodies are more probably going to attach, to deposit in three most important tissue, which you guys have to keep in mind, right? So they can just attach or deposit in the, in the joints. In the joints, that's really important, right? So, okay, what else? In the skin, what else? Hello, do you guys know that? Three important things, three important places where we can have more deposition of these kidneys. Okay, kidneys, skin, and joints. So whenever we have a problem, a patient with the problems of kidneys, skin, and joints, so you should just keep serum sickness in your mind, and it can be seen in type 3 hypersensitivity. That's really important. Like for example in SLE, right? In SLE, we have joint problems. The most common cause of death in SLE is due to renal failure. We have the malar age, right? All of these three things are present there, right? So most probably we are going to be having the serum sickness in type 3 hypersensitivity, right? Is it clear? Okay. But remember one thing, these immune complexes are going to be made after, like 1 to 2 weeks later, right? Once we have an administration of any foreign protein, right? So sometimes we can have like, these antibodies against like anti-venom as well, right? Anti-venom. Like for example, we know that what are the anti-venom for a snake bite? That's basically antibodies from horse, right? But still they can be antigen to your body. So we can have antibodies formation against that. It would just take 1 to 2 weeks. They can just build in number, they can deposit in different tissues and giving us this type 3 hypersensitivity. We discussed SLE as well. That was basically antigen and antibody complexes against your DNA, right? Okay, reactive arthritis, polyarthritis nodosa, post-strep glomerulonephritis, if you guys remember, right? Post-strep, after a streptococcal infection, most commonly seen in children. We discussed that in detail if you guys remember, right? Is it clear? So we are going to be having fever, urticaria, arthralgia, and proteinuria, right? You guys can see it. Serum sickness-like reaction are commonly seen in certain drugs as well, the haptens, right? That is penicillin, monoclonal antibodies, and any kind of infection by hepatitis B. That's really important to know, okay? Is it clear? Hello?
Yes.
Yes.
Yes, sir.
Okay. So what is Arthur's reaction? Do you guys have any idea? We did it, guys. Just please participate.
Can you please repeat?
Vax-
Arthur's
Arthur's
reaction.
reaction. It's seen in booster vaccinations.
Mm-hmm. Okay, seen in booster vaccination. Okay. What would happen? That's also an example of type 3 hypersensitivity, right? So basically in booster vaccination, we can have like, an intradermal injection of an antigen, you know, and as a result of that, we can have antibodies against that antigen. That's an example of type 3 hypersensitivity. And immediately we are going to be having edema, fibrinoid necrosis, and activation of complement system, which would appear in the
And
form
fever.
of yes, and fever as well. Okay. So these are the things which are basically seen in Arthur's reaction. Let's just come to our last hypersensitivity, which is type 4 hypersensitivity, right? So type 4 hypersensitivity, whenever come in your brain, you should think of T cells, right? T cells, type 4 hypersensitivity, T cells, right? So we have direct cell toxicity by which cells? CD8 positive cytotoxic T cells, right? Okay. CD8 positive. They are cytotoxic T cells. We know that, right? And inflammatory reaction via CD4 T cells recruiting your macrophages. That's really important as well, right? Macrophages. Okay. So we know that we have CD4, TH1 component of CD4. They can just recruit, macrophages to the site. Okay. So we have direct CD8 positive destruction or either destruction by those macrophages, cytokines attracting macrophages. Is it clear? So, okay, so the response does not
Yes,
involve
sir.
antibodies. We know that here we do not have any antibodies involved. It's purely by the T cells, either cytotoxic T cells or the helper T cells recruiting your macrophages, right? So the example of that are contact dermatitis. So what is your contact dermatitis? We know something called a poison ivy. If you remember the urushiol component of that, whenever we have an individual, he was traveling through, forest and he was in contact with some plant and suddenly he developed indurations there, some reddish kind of spots, right? That was an example of contact dermatitis. So contact dermatitis, it's type 4 hypersensitivity, T cells coming there and causing the problems, right? Okay. We have nickel allergy as well. Like some of the watches are made up of nickels, right? Nickel is being used in that. So in some individuals, the nickel exposure to the skin can, induce this type 4 hypersensitivity, in which T cells are going to be causing problems there, and it can just give you problem, right? So the next one are okay, graft versus host disease. We are going to be doing that in our transplantation. So we discuss, if you guys remember, whenever we transplant either the bone marrow or whenever we have transplantation of liver, so sometimes the bone marrow and the liver can have a lot of reservoir of your T cells. It can start destroying the recipient, right? So that's a graft versus host disease, which we are going to do in a bit, right? Okay, Nama's break after 5 minutes. Definitely, we are going to have a break, right? Then we have PPD and TB infection, right? So, if you guys remember, we do a PPD test. What is a PPD test? It's really simple. We are going to take some component of the TB bug. and we are going to inject it inside the body. If your body have already been exposed to TB, okay, TB was basically your granuloma formation involving macrophages, remember? So your body already is, if in the previously, TB can be in a latent form, right? So if an individual is already exposed to TB, you are giving him PPD. So obviously he's going to be having memory against that, component. So we are going to be having a local induration there in the skin, which is basically a positive PPD test, right? Which indicates that yes, this individual in his previous ages might have been infected by the TB, right? Similar is the example of Candida, right? So we do Candida skin test. We are going to take some component of the Candida, give it under the skin, and after that, we are going to be having T cells immune function there, right? T cells just coming, causing a local inflammation and induration there, right? So that was also an example of type 4 hypersensitivity. Keep these things in mind. You're going to be having a UWorld MCQ. They're going to tell you that we have an individual, we give them a candida skin test, this, that, and everything. So which cells are involved in, causing this local induration or local inflammation. So that would be your T cell. Is it clear? Similarly, the PPD test for TB. That are basically your type 4 hypersensitivity involving T cells. Similarly, you're going to have MCQs, related to poison ivy, nickel, okay, and drug with, okay, the DRESS syndrome, you're going to be doing that, and graft versus host disease, which we are going to do in a bit. Is it clear? Hello?
Yes.
Yes, sir.
Okay, great. So let's have 5 minutes of break for Nimas, and then we're going to be starting. Please explain energy. Okay, I'm going to explain energy. Okay, okay, so it actually is basically both type 3 and type 2 hypersensitivity, right? But the main thing is type 3, the problems which you are seeing. But in SLE, we have pancytopenia, that is destruction of your cell lineages as well, like destruction of your red blood cell. That's an example of type 2, right? So if you remember, we discussed that in autoimmune hemolytic anemia can be seen in individual with SLE, because in SLE it's an autoimmune condition. Sometimes we can have antibodies against the red blood cells, the platelets, which can lead to destruction of them, right? So the destruction, the part where we are destroying our own body's cells, like red blood cells, the you know the platelets, that component of SLE is type 2 hypersensitivity. But in general, SLE is type 3 hypersensitivity. Is it clear? We are going to explain the energy concept just in a bit after the mass break. Okay. Okay. Hello.
Okay.
Perfect. So let's have 5 minutes of break, and then we are going to do it. Okay. Thank you so much. Hello.
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 Yes, sir.
Yes, sir.
Okay, that's great. So let's start our. Mhm. Okay. So that was all about our hypersensitivities, right? So let's discuss our next one. That is, okay. What was the next topic? That was your transplant rejections, right?
Graft versus host.
Yes. Let's see transplant rejections now. Okay. What's the page number? Can anyone just please tell me the page number?
It's 2024 117.
Okay, 117. So let me see. Okay, that's great. So let's discuss our transplant rejection. So, what are transplant rejection? First of all, you guys must be having an idea, right? So we have donor and we have recipient, right? What is donor? Donor is anyone who is donating, right? And recipient, anyone who is just taking that thing, right? So we can have sometimes the recipient can, reject the donor, right? The donor graft. So that's the concept of transplant rejection. So we have a lot of types of transplant rejection, which includes hyperacute, acute, chronic, and that's graft versus host disease, right? So the difference between all of these three, how to differentiate whether it's hyperacute, it's acute, it's chronic, or it's graft versus host disease. That's time. For example, if in a question stem they're just telling you that we just did a transplant and right within minutes we see fibrinoid necrosis and the GFR just dropped and and we have to remove the graft. What do you think? Which type of rejection it is? So it's your hyperacute, right? So hyperacute occurs within the minute, even on the operating table. It's going to occur on the operating table, right? Okay, so it's going to occur within the minute. So what is the pathogenesis? Pathogenesis is really important, right? Basically, in why do we have so fast response, so fast rejection of a graph? This fast rejection of graph is basically due to type 2 hypersensitivity. In type 2 hypersensitivity, we discuss that we'll be having preformed antibodies like, for example, if I'm an individual with B positive blood group and you are an individual with A positive blood group, so me with B positive, I already have preformed antibodies against A. The A already have preformed antibodies against B. So if I'm just getting blood from an individual with A positive, I'll immediately destroy them. I'll immediately, that blood is going to be an antigen for me. So my antibodies are immediately going to go there. While type 2 hypersensitivity, they are going to destroy the blood. Similar is the case if I'm just giving you my blood, right? So we have preformed antibodies. That's why the response is so quick within minutes, right? So pre-existing recipient antibodies against the donor antigen, right? The antigen here can be two things. Remember, one of them are HLAs and the other are ABO. These two things, right? So either in the transplanted organ, we can have some remnant red blood cells, of different blood group against which our antibodies or the recipient antibodies can attack and it can lead to hyperacute rejection. Or either the HLAs. Do you guys know what are HLAs? We discussed that in detail. Anyone? HLAs.
3%.
These are the genes.
Genes.
Gene
Yeah,
code.
that
Many
these
Major
are
genotypes.
histone
study
complex.
code for HLAs.
Major
For
Perfect.
histogram.
MHCs.
So they are the cluster of genes basically, and these cluster of genes encode for your MHCs, right? We know that. So sometimes your HLAs can be different than mine. So if I just transplanted something from you, so it can be an antigen for me, right? So the HLAs and the ABO can be, the antigens in these cases in hyperacute rejection, right? So what are going to be the features? We're going to be having thrombosis of the graft vessel. The graft vessel is directly going to undergo thrombosis, ischemia, and fibrinoid necrosis. Ischemia and fibrinoid necrosis. That's obvious, right? These are going to be the responses which are going to be seen in hyperacute rejection, right? Thrombosis, we know that if we have inflammation there, we are going to be having thrombus. That's really simple. For example, in the glomeruli, fibrinoid necrosis, where do we see fibrinoid necrosis? If you guys remember in hypertension, basically you are seeing fibrinoid necrosis, right? So just keep that thing in mind. In hypertension, along with acute rejection, we are going to have fibrinoid necrosis. The other one is acute rejection. What do you see in acute rejection? First of all, you should be knowing the timeline. If the rejection occurs within weeks to months, then that's going to be our acute rejection. If it occurs within weeks to month, that's going to be our acute rejection. Is it clear? Hello?
Yes, sir.
Yes.
Now, the next thing which you should just keep in mind is that this rejection can either be due to type 4 hypersensitivity, or either it can be due to which one? Type 2 hypersensitivity, right? Two things. Either the rejection is going to be due to type 2 hypersensitivity, or either it can be due to type 4 hypersensitivity, right? It's really important to know it, okay? But it can either be, I just mentioned either be, right? If they are both of them going at same time, that's going to be an example of your chronic, right? So in acute, either it would be type 2 hypersensitivity or, hello, or either it can be type 4 hypersensitivity. So we discussed what was type 4 hypersensitivity. In type 4 hypersensitivity, we can have CD8 positive T cells either destroying your your host, your graft, right? Or either it can be CD4 positive T cells activating your MHCs and destroying the host, right? So that's type 4 hypersensitivity. Either you can have type 2 hypersensitivity. Okay, is it clear? Hello? The response is
Yes.
almost same as that of hyperacute, but in hyperacute we were having preformed antibodies. While in this case, your antibodies are going to develop after the transplant, as they're mentioning here in the first year, right? So let me just ask you a question. Let me just ask you a question. For example, if we have a tissue specimen, right? And in that tissue specimen, we just look for if you are having some T cells within that, okay, and that tissue specimen was basically from graft, which was rejected within weeks to months. So, what do you assume? Is it due to type 4 hypersensitivity destruction of that graft or rejection, or is it due to type 2 hypersensitivity?
Type 4.
Type 4
Type 4.
hypersensitivity.
Perfect. If you have T cells
Type
there,
4.
it's going to be your type 4. But for example, if there we see some decreased complement marker, decreased C3 and C4, then what would you assume? Would it due to be type 2 hypersensitivity or type 4?
Type 2.
Type 2.
No,
Type
type
two
Type
2.
can
2.
be.
Type 2.
Because we
Complement
discussed
type
in
2.
type 2 hypersensitivity, complement is going to be undergoing the destruction. So whenever we are using the complement and we are looking towards C3 and C4, that's going to be very low, right? So that is going to indicate the low C3 and C4 is going to indicate that we have type 2 hypersensitivity going on there, right? What would be the present day? What would be the the gross features? Would be vasculitis of the graft vessel with dense interstitial lymphocytic infiltrate. If it's due to type 4, then we'll be having lymphocytic infiltrate. Keep that in mind, right? How to prevent it? Give immunosuppressants. We discussed the concept of immunosuppressants, right? In detail. Calcineurin inhibitor, mTOR, we discussed that. So that's basically going to decrease the T cells proliferation. And as we decrease the T cells, as we are suppressing the immunity, so the chances of T cells being killing your own body parts or rejecting a graft is going to be decreased. What's chronic? Chronic is chronic, a long period, months to year. If we have a rejection, along a greater period of time, that is 1 to year, that's basically going to be a chronic variant of that, right? And in chronic, remember, we are going to be having both type 2 and type 4 occurring at same time. In acute, we discussed we can either have type 2 or we can either have type 4 hypersensitivity undergoing the destruction of a graft. But in chronic, we are going to be having both type 2 and type 4 hypersensitivity occurring at the same time, destroying the graft by the VCT. Is it clear? Hello? Hello. So we are going to be having
Yes, sir.
CD4 positive T
Yes.
cells response to recipient antigen presenting donor peptides. If you have that peptides, we know that CD4 the entire pathway, right? present on MSC and everything. And we can have type 4 due to T cells, type CD positive T cell toxic, destroying your destroying the graft, right? So it's going to be dominated by arteriolosclerosis. We discussed what is arteriolosclerosis. The arteries are going to become sclerosed. That was a manifestation of a chronic phenomena, right? It was a manifestation of chronic phenomena. What do we see in chronic phenomena? We discuss whenever we have chronic inflammation or chronic phenomena, we have fibrosis there. We're going to be having atrophy because we are chronically destroying. We are destroying the graft really slowly. So as we are slowly destroying the graft, so in the end, you're going to be having atrophic parenchyma of that fibrosis because destruction itself is going to be followed by fibrosis. Fibrosis is the most common feature of chronic phenomena. As you guys know that, right? Okay, so organ specific examples, bronchiolitis obliterans. Really important. You can have a U word MCQ on that. Accelerated atherosclerosis. Atherosclerosis itself is a chronic phenomenon, right? So we can have this. Vanished bile duct syndrome. Sometimes these immune cells can damage the bile duct, right? No, having no bile duct there. Bronchiolitis obliterans. Sometimes the bronchioles can be affected by this condition in case of lung transplantation called bronchiolitis obliterans, right? So that was all about the chronic rejection. Let's discuss graft versus host disease. Both hypersensitivities are present at the same time in chronic transplant. Yes, both are present at the same time. Both are present at the same time. Graft versus host disease. Till now, we were discussing your recipient rejecting the donor. The recipient was rejecting the donor graft. But in graft versus host disease, the donor is causing problem within the recipient. That's all. Okay. In graft versus host disease, the donor graft is causing problem. Graft versus host disease. It's the graft which is causing problem in a recipient. So you can see it's like entirely, opposite than whatever we did. Okay. It's basically the graft causing the problem. So how do the graft causes the problems? That's really important to know. Okay. So it's only going to be seen in two cases. If either we are transplanting, the bone marrow, or either we are just transplanting liver. Why? Because in bone marrow and liver, we are going to be having a lot concentration of T cells. T cells, right? In liver and in the bone marrow, we are going to be having a lot of T cells. Normally, it includes a lot of T cells. So, for example, if I undergo, the transplantation of the bone marrow or a liver, as they're already having a lot of T cells, so those T cells within the graft can cause problems within the host, within the recipient. Those T cells can just come out. They can in turn attack, the skin of a host. It can attack, or it can just invade into the liver of the host, causing problems there. So this was the concept of graft versus host disease. Are you guys clear? Let's read the text now. Are you guys clear that what's the concept of graft versus host disease? That's basically the graft causing problems within the recipient. But which kind of grafts? Only two kinds of graft can do that, either bone marrow or either the liver, because they have a big reservoir of T cells, and T cells here are going to be causing problem. So if the T cells are going causing problems, so it's an example of which hypersensitivity. Yes, type 4 hypersensitivity, right? Hello.
Yes.
Okay, perfect. So here you can see the grafted immuno T cells are going to proliferate in immunocompromised hosts. The T cells can, invade, or it can just cause infection within the host if the host is immunocompromised. We know that, right? So it's going to be seen in, okay, we are going to have maculopapular rash, like these T cells can invade the skin, causing a maculopapular rash there, jaundice, diarrhea. It can just cause, problems within the GI, hepatosplenomegaly, in the skin. We are going to have an attempt to kill those. So we are going to be having hepatosplenomegaly. Joined us, if we just transplanted the bone marrow, it can kill the liver of a recipient as well. It can damage the liver, causing jaundice. Okay, keep that in mind. So its potential, okay. So for the patient who are immunocompromised, irradiate the blood product prior to transfusion to prevent GVHRD. GVHRD is graft versus host disease. So if an individual is already immunocompromised, so you never would do that. Okay, you never would just do a transplantation specifically of your liver, specifically of your bone marrow in that individual, because we can have chances of getting graft versus host disease. Is it clear? It's type 4 hypersensitivity. Is it clear?
Doctor, can you please repeat last
Yes,
line?
please. Okay. So the last line basically indicates that if you are having immunocompromised individual, right? So irradiate blood products prior to transfusion to prevent GVHRD, right? Even in those individual, you are going to prevent the blood products as well. Because if an individual is already immunocompromised, right? Immunocompromised. So the blood itself can sometimes contain these, these T cells, right? They can cause graft versus host disease, right? So you are going to be really, conscious about immunocompromised individual, right? Really conscious about immunocompromised individual because that makes sense. If you are just giving them, a reservoir of T cells that is liver or, any kind of, bone marrow transplantation. So as they are already immunocompromised, so the T cells from these grafts can cause a lot of problem in them, right? Because they are immunocompromised, right? So even the blood products are also going to be avoided in these individuals because they can have a lot of bugs despite of having T cells, you know, causing problems. Is it clear?
Yes, doctor.
Why do
Okay.
we have arteriosclerosis in chronic transplant rejection?
Why do we have?
Arteriosclerosis in chronic transplant rejection?
Okay. Okay. So first of all, you should know what is arteriolosclerosis. Okay, you are talking about in transplant rejection. Why do we have in chronic transplant rejection? Why do we have atherosclerosis or arteriolosclerosis? Arteriosclerosis.
Arteriosclerosis.
Okay, arteriosclerosis. So first of all, you should just keep one thing in mind that why do we get arteriosclerosis? Do you know the okay next step? Okay. Do you know what is arteriosclerosis? Whenever your small arteries get sclerosed, that's your arteriosclerosis. If you guys remember from cardiovascular section, we discussed two variants of arteriolosclerosis. Can you just please tell me that?
Hyaline and hyperplastic.
Hyaline and
Hyper.
hyperplastic. In which condition you were seeing hyaline arteriolosclerosis?
Diabetes. Hypertension.
Diabetes.
Diabetes and
And
hypertension.
Diabetes
hyperplastic
and
was basically
hypertension.
seen that was causing diabetes and hypertension. So arteriolosclerosis. In chronic transplant rejection, these T cells can cause, damage of your, these T cells can cause damage of your arteries, small arteries, which can lead to arteriosclerosis. Like in case of hypertension, we were discussing that increased pressure is going to cause like many kind of damages there you can just simply think of, and as a result of that the smooth muscle layer was just proliferating in a form of onion skin if you remember, right? And it was causing that sclerosis. So if we have direct damage by T cells or either the antibodies, so in order to compensate those damage, obviously the smooth muscle of your arterioles are going to proliferate and is going to lead to arterial sclerosis. Is it clear?
Yes.
Hello. Okay.
Yes.
Okay. And another thing, how to remind it, arteriolosclerosis and atherosclerosis, both of them are slowly developing processes, right? Like our atherosclerosis develop really slowly, right? Really slowly. Okay. And arteriosclerosis itself develop very slowly whenever you have an, any factors like, which leads to atherosclerosis, for example, smoking, if you have diabetes, but still it's a slow process, right? So in chronic phase, again, you are going to be having these atherosclerosis and arteriosclerosis because they are chronic or slow processes, right? Which can occur due to, chronic exposure to, T cells or, type 2 or type 4 hypersensitivity. Is it clear? Hello? Okay. So let's discuss our
Yes.
vaccination. Okay. Let's discuss vaccination. Okay. So the concept of vaccination is really simple, right? Okay. Before discussing vaccination, let's do passive and active immunity, right? What is passive immunity? It's a spoon fed immunity. Whenever we are giving a preformed antibodies to anyone, like for example, the baby get IgA from the mother in the breast milk in order to, save itself from mucosal infections because IgA is important in providing immunity to your mucosal surfaces, right? So that was a passive immunity. But if we are training your body cells, the T cells, if you're training the B cells to get a proper response or a proper memory, that's basically your active immunity, right? So active immunity is basically going to be given by two things: the natural infection or vaccination. So if an individual is naturally going to get infected, a natural infection, so what would happen? Your T cells and B cells are going to be exposed towards that, and in that way they can train themselves. They can form memory against these infections, right? So as they get trained, as they have memory, so in the future, whenever these individuals are having same kind of problems, so what would happen? Your body already have memory, they have already been trained, so they can easily destroy the bugs in future, right? That's basically your active immunity, right? So in vaccination chapter, we are probably going to be considering the active immunity, right? So live attenuated vaccines we discussed already it in detail, but I'll be having a quick overview. The killed vaccine we discussed it, the combined conjugate and toxoid and mRNA, right? So the idea here of giving live vaccine. So in live vaccine, what do? We take a bug, and we weaken the vaccine, right? Okay. Okay. Just please give me a second. Okay. I'll be back in. Hello. Hello.
Yes, sir.
Hello. Can you hear me? Okay, that's great.
Yes.
So
Yes.
let's discuss about live, right? So for the live attenuated vaccines, we discussed that we are gonna take a live bug, and what we are gonna do with that, we are going to remove the pathogenic component of that, right? The portion of the bug which is causing problems, which is causing infection, we are gonna remove that, right? So we are going to remove the pathogenic component from the bug, but still it is immunogenic. The bug is going to be still immunogenic. So what do you mean by immunogenic? Like still you can train your immune cells with that bug, but the good thing is that we have removed the pathogenic component from the bug, it won't cause any problem, but it can train your blood your immune cells, your T cells, your B cells, right? Live attenuated vaccine. So it's a live bug, but we are just removing the pathogenic part of from that, and as a result of that it can just cause you can have immunogenic component of that. You can train your immune cells as a result of that, but it won't cause any pathogenic problem. The pathogenicity isn't there, as we have removed the component which is causing pathogenesis. That's simple, right? So the example for that is MMR. Okay, so what are the pros and cons? First of all, let's see that, right? The pros are that we can induce a humoral response and both cellular response. So if you remembered, how do we, generate a cellular response? You guys know the cellular response is, generated by, infection. Like this bug still have the ability to infect your, let's suppose, dendritic cell, right? So if infect your dendritic cell, you know it can just go into the cell presented on MHC1 in this case. If the vaccine is a virus, and it would just be presented on MHC1, and there the CD8 positive cells can come, and those CD8 positive cells are going to destroy them, but you are going to be having some memory, right? So there's basically going to be the cellular induced memory, right? Cellular component. You can have humoral response. Like sometimes this bug is going to be taken by the dendritic cell. They're going to present it on MHC2. Once they are presented on MHC2, you can have a humoral immunity. You can have activation of your B cells, and as a result of that, the B cells can give you humoral immunity, making IgG. Is it clear? Hello? Hello?
Yes,
Okay.
doctor.
Okay. But what's the problem with these live bug? The problem with these live bug is that they can reactivate, they can get mutated, they can cause infection, right? So you will be giving them to train your immunity, but sometimes they can undergo mutations, and they can cause a real kind of infection in individual. That's the cons. The are that you can have a best immunity, right? The idea is that you are just exposing an individual to a real bug, right? So it's better going to have a better training, right? If you're just putting army into a real kind of war situation, they're going to be having a better training of that, right? But the problem, what if the war just turned into a real war? That's the problem, right? And they are killed, so that can be a con cons. Okay, so you can see that, right? So in the okay, so the microorganism, we remove the pathogenic component, and then we are going to give them, what are the example of them? The MMR vaccine, right? Okay, we are going to do it in examples, right? So you can see in HIV, okay, but we are going to not give an individual who are immunocompromised. For example, if you are just making a war situation on a country which do not have any army, right? So you will be doing it for the training purposes, but you are going to destroy the country, right? Because you do not have army. So in case of HIV, we know that the CD4 cells are going to be really low. If the CD4 cells are low, so you cannot even put them into the training situation, right? You cannot give them the live vaccine. You can just cause infection. But for that, you have to look for the CD40 count. If it's greater than 200, you can put that into the training situation. But if it's less than 200, you would never want them to put in the training situation, giving them these live vaccines, right? So example of live vaccine, you can see is here. There's a mnemonic: attention teacher, please vaccinate small, beautiful yellow infants, okay, with MMR routinely. So adeno, typhoid, polio, varicella, smallpox, BCG, yellow fever, influenza, MMR, rota, everything. Just you have to memorize it. But the difference is that oral typhoid, or in its oral form, is live, but typhoid intranasal, right? Okay, typhoid here. Okay, that intramuscular. Sorry, intramuscular is a killed, right? So oral is alive, while intramuscular is killed. Okay, so here you can see the other one as well. The influenza intranasal is live, but influenza intramuscular is killed. The polio sabin is live, but the SARC is killed. Okay, so these are the difference which you have to just keep in mind. The other one is killed. If you just give a killed vaccine, just removed all of, we just kill them. So still it can, you can train your body with it, right? The example for that would be that in the first situation, we were using guns in training process without having bullets, right? Okay, but in the second situation, we are using fake guns, right? Fake guns. So still with the fake guns or the killed vaccine, you can train your immunity, right? So the pathogen is inactivated, it's being killed by heat or by chemicals, but maintaining the epitope structure on the surface, which can be used for the training purposes of your immune cells. Keep that in mind, right? Which can be used. What are the pros? They are safer. They can never cause infection because they are dead. Yes, water gun. Okay. So they are safer. They can never cause a problem, right? But the cons are they can have induce a weak kind of training. It's a weak kind of training if you're using water guns, right? We already know that we won't be killed by water guns, so we cannot be properly prepared for that situation. So it's going to be making a weak immunity, right? Weak. Okay. It's only going to induce a humoral response, because these bugs do not have the ability to infect a cell. And cell infection was important to get cellular immunity, right? That CD8 positive. We need to infect a cell in order to present those onto MHC1 and then get our CD8 positive. But if we cannot infect a cell with the killed, we can never get cellular immunity. But yes, we can get humoral immunity if the bug is having any peptide antigen, if you guys remember in mind, because MHC2 is only able to present the peptide antigen, right? So in the killed vaccine, in the killed bug, if we remain some of the peptides of that bug, still you can get a humoral response. But the problem is that it's going to be really weak. So you are going to give them booster doses, right? The idea is that you are going to keep them training again and again, because they are not well trained, right? Example for them. Are you guys able to understand? Hello.
Yes, sir.
Yes.
Yeah.
Yes.
Okay, that's great. So hepatitis A, typhoid we discussed, rabies, influenza, polio, the SARC variant. Okay. The other one is the sub. Okay, okay. Yes, it's a booster dose. Okay. So subunit, recombinant, polysaccharide, and conjugate. We discuss using the polysaccharide component. You can also train the immunity. But the problem with that is polysaccharide can never be loaded onto your MSC2. So if you cannot load it onto MHC2, you won't get that TH dependent B cell activation, class switching antibodies, right? But polysaccharide, okay, there are two ways to get your B cells activated, right? There are two ways to get B cells activated. What are those two ways? You can either activate B cells via TH dependent pathway, or you can directly activate T cells. How? Yes, there are two ways. What are the two ways? Who's going to be telling me that? Hello?
Yes, sir. Please repeat the question.
Okay, my question. There are two ways to activate your B cells. One is TH dependent, the other is T cell independent activation of B
Independent,
cells.
yes.
Right?
Yes, sir.
Right. So in the independent B cells, the B cells are only going to release IgM, right? But the TH dependent, okay, you should just keep one thing in mind. For the TH dependent, in order to activate the B cell via TH dependent pathway, first of all, the antigen should be a peptide. You know that. Why? Because
Yes.
only peptide can be loaded onto MHC2. And once that's
Minus,
loaded onto
yes.
MHC2, you can have CD4 a response, TH2, you can have B cells that can undergo class switching, and it can give you a lot of variants of antibodies, right? Yes. But we can sometimes have TH independent activation of B cells. What happens in that? We're only going to be, stimulating the B cell to make IgM, because we know that the B cells can make IgM. That's going to be the first antibodies being made by your B cells, right? Is it clear?
Yes. Yes.
So if I'm
Shortly.
just giving a polysaccharide, if I'm just giving a polysaccharide, so I would activate the B cell, but that's going to be TH independent activation. Only IgM is going to be. And IgM is not a good, it can be, it do not have a
No,
good
long
memory, I
term.
can say, right?
Yes. Short term.
Yes,
Short.
they do not have a long-term effects, right? IgG is the one who have long-term effect, right? So for that, what should I do? I should just conjugate it with some peptide antigen. Let's just combine some peptide with the polysaccharide, and as I combine those peptides with the polysaccharide, now I can load it onto MHC2. Now I can have TH-dependent B cell activation, which can give me the IgG, which are good for your immunity. You are going to be having a UWorld MCQ. They're going to ask you, you have an individual. He was having a kind of, he was having getting a conjugate vaccine. So he asked from the doctor, why did you conjugate it, right? So the doctor just told him that I want your B cells to be activated by TH1 pathway in order to get IgG for your better immunity, right? But he didn't understood, because he didn't have any medical knowledge. But hope so you guys understood it, right? Why was he just doing that? Okay. So the target for a specific epitope, lower chances of adverse reaction. We know that, okay, these are the examples. You can just read the examples. Okay, the HPV, the HPV, acellular pertussis, Neisseria, meningitis, streptococcus, polysaccharide. These are your, polysaccharide, the TH independent, while PC13 and this other, okay, just memorize it, okay? Really sorry for that portion. It's pure memory. Just memorize it. Just practice as much as you can, okay? So let's start with toxoid. What is your toxoid vaccine? So basically, the denatured bacteria toxins. Okay, do you know what are toxoids? First of all, what are toxoids?
These are chemically these are the toxins actually when they go some chemical process or heat process that they are not more pathogenic is called as toxins.
Okay. The toxins. Sometimes some bacteria can just make some toxins, and we can train our body with those toxins, right? Because the concept of vaccination is training your body, right? For example, the tetani, Clostridium tetani, right? It make tetanus spasm, something like that, if you guys remember, right? So we can just take that tetanus spasm, and what would we do? We would just denature the entire component of that bacteria, but we would only leave the receptors, right? The receptors are going to be only left on that. What's the importance of those receptors? It have the immunogenic component. You can train your body with those receptors. Just simply keep that in mind, right? So it would simulate a system to make antibodies. What are the pros? The pros are they protect against bacterial toxin. What are the cons? The antitoxin level decreases with time, so we have to give them the booster doses, right? So we are just killing the entire toxin. We are only leaving the receptor component of those toxin, and the receptor component have the ability to train your immunity, right? But the problem is that you should be given booster doses, because it have very weak, training ability, right? So example for that is Clostridium tetani, Corynebacterium diphtheria. Okay. The last one is mRNA. It's really important and really simple as well, right? What is mRNA? We know that the messenger RNA go through your ribosomes and they make proteins, right? We know that, right? Hello.
Yes, sir.
Okay. So sometimes what we would do, we would just take an mRNA from a bug, let's suppose, right? So this mRNA, once it's given to an individual, this mRNA is gonna go. It's going to interact with the, with the ribosome. For example, if I'm just training myself, right? If I have injected into myself, so that mRNA is going to use my ribosomes to make the component of a pathogen from whom I have taken the mRNA, right? For example, in COVID, right? For example, from the COVID bug, let's suppose, right? I just took some mRNA, which are basically encoding, the spikes region of the bug, right? The spikes region, and I inject only that small RNA into my body. So those small RNA is going to use my ribosomes to make the spikes for the COVID, right? Hello.
Yes, sir.
Okay. Okay.
Sir, can you
So
please
it would.
repeat?
Okay. Let me just repeat it. The messenger RNA, right? Okay, what is messenger RNA? You guys know that the messenger RNA, if it's in me, if it's in bugs, if it's in viruses, anywhere, right? So its goal is to make cause translation, have translation in ribosomes, right? So they are going to pass through the ribosomes and they're going to make proteins, right? Peptides, right? We know that, right? Hello.
Yes, doctor.
For example, if I just take Doctor you as an example, and if I want to train you against the COVID, right, the COVID virus, let's suppose, right. So instead of getting all of okay, and the pathogenic component of that bug is the spikes, and the spikes have the ability to train your immunity. So what's the use of getting the entire bug into you? Let's just take the mRNA, which is encoding for the spikes portion of that bug. Let me give you that mRNA. That mRNA is going to use your ribosomes to make those spikes, and from those spikes you can train your immune cells. Is it clear?
Yes, doctor.
Okay. So instead of getting the SARS-CoV-2, I would just take an mRNA. Okay, first before getting mRNA, you should know that the spikes portion are really important to get you trained. We need the spike portion only. So why should we just take the spike? Let's just make it simple. Let's take the mRNA which encodes for the spike. Those mRNA is going to go into your body. It's going to make the spikes using your ribosomes, and through that you can just train your immunity. What are the pros? It have high efficacy. It induces cellular and humoral immunity safe in pregnancy. It would both induce cellular and humoral immunity because the spike portions can infect your cell. And as we infect the cell, we can get cellular immunity. The spike portion are, yes, please, any questions? Hello? Okay. So those spikes of this bug have the ability to infect the cell. Presented on MHC1, we can have the CD8 positive response. Okay. And we can have humoral. Those spikes portion can be loaded onto MSC2. It can activate your Th2 response, get your B cells activated, and those B cells in turn can cause this, humoral response, giving you IgG, which is going to be really safe, for your immunity purposes. Okay. Okay, the cons are that the local and transient systemic, it can cause a lot of problems, right? This mRNA. Remember, it can cause fatigue, it can cause headache, it can cause reaction, it can cause myocarditis, pericarditis as well. So you might have listened a myth, right? The people were discussing that as they get vaccinated with COVID, so a lot of people are dying due to heart attacks. Even the young people are dying. The reason was that using this mRNA as a vaccine, it can cause myocarditis and pericarditis, right? Is it clear? Hello.
Yes, sir.
Okay. So that was all about vaccination. So let's just do our last other topic. That's going to be our cytokines, right? Energy. Okay, let's discuss the concept of energy, and then we are going to discuss our last that is cytokines. Okay. Okay, Dr. Nimra, you are asking about energy, right? So you have to be, communicating with me. I'm going to ask you some questions, and you're going to be answering me that, right? Do you know what is central tolerance? Hello, please turn on your mic. Hello? Hello? No responses, right? No one is just responding me. I'm really sad. Hello?
Yes,
We,
Crystal,
we
you
are
are
here,
asking
No.
from
doctor.
the
We are
line.
here.
We are here.
We are
Sir,
waiting for
they are
the
here. So I thought you were
Oh,
asking her.
oh,
So
thank
yeah.
you so much. Thanks,
yes.
God. I thought you guys are ignoring me. Okay. So okay, who are okay? Okay, Doctor Nimra. If Doctor Nimra is ignoring me, so you guys must be there to save me from this ignore, please. Okay. Anyone else? Okay. Can anyone just tell me about central tolerance? We discussed central tolerance. What was your central tolerance? Hello.
Sir,
I think we're not sure about
according
it.
to yes,
Actually, I
not
think
sure
it's the
about it. What
process
Not sure.
in
tolerance?
which the body cells are preventing to attack their own bodies, something like that, like lymphocytes.
Oh, perfect. Perfect. So let me just tell you the concept. Remember, in our thymus, we were discussing positive and negative selection. We discussed that positive selection was basically okay. What were we seeing in positive selection? Those who are showing love, they're positive, leave them, right? Okay. And what was that? Whenever the MHC1 are binding well to your CD8 positive T cells, we are going to spare their life. If MHC2 are binding well with your CD4, we are going to spare their life because they are showing love. We need that. We need that interaction. Let, let them survive. In the negative selection, you should not show love to your own body parts. You should not show love to your own body parts, your own body tissues. So what were we having in negative selection? Okay, we were having an airy company making cars. Remember, those cars were just bringing. If you
Yes.
guys remember the story which I just told you, right? Those cars were bringing a lot of antigen from your body parts, and those T cells which were showing love to your own body parts, you were killing them, and that's really important because we do not want T cells to interact against our own body tissues. Is it clear? Yes or no? Hello?
Yes. Sir.
So negative selection was
Yes. Yes.
basically a way, okay, negative selection was basically a method, which nature have given us to save us from T cells destruction, to save us from autoimmunity. That's also called central tolerance because this process is done in your thymus. That centrally, central tolerance is your negative selection. Negative selection is your central tolerance. So what is central tolerance? You are saving your body against your T cells to being destroyed by the T cells. That's a concept. Okay, that was your central tolerance. We nature have given us something called peripheral tolerance as well. Okay, we know that how do T cells undergo destruction? We know that the T cells are going to bind with, let's suppose, okay, for example, if you have a CD8 positive T cell, let's just take an example of CD4 positive T cells. We know that CD4 is going to bind with the MSC2. We know that, right? Am I right?
Yes.
Yes.
But we have a co-stimulatory receptor as well, B7 and 28. Where do we find B7? On antigen presenting cell, right? Hello?
Yes. Yes.
Yes.
Of course,
Yes, sir.
stimulate.
Okay,
Yes,
and
sir.
once, yes, okay, so listen it again. For the proper activation of T cells, we do not only need, a single receptor. We need, the CD,
Two
B7 and
series.
28 as well to interact in order to have proper functioning of the T cells, right? But the problem is that B7 is only present on antigen presenting cells. Does that make sense? So, for example, by any chance, if the central tolerance failed, if the negative selection failed, and you have some T cells against your kidney, let's suppose, and they're just coming out. So, what these T cells are going to do? They are going to, they're going to attach to your kidney. But since your kidney cells are not antigen presenting cells, right? Hello? Are your kidney cells antigen presenting cells? No, they aren't
No.
antigen presenting cells. It means they won't be having B7 on their surface, right? They won't be having B7 because B7 is only present on your antigen presenting cell. So, in that way, your T cell would come, it would try to eat your kidneys, but as the kidneys do not have B7, so the kidney cells will just, tell the T cell, I have recognized you. I do not have T cells. You are here to kill me. but I am not an antigen. So sleep, just sleep. It will just tell the T cells to sleep. That sleeping is called energy, right? Sleep. Do not kill me. You can't kill me because I do not have B7. I am not an antigen presenting cell. So nature have given us a second mechanism of peripheral tolerance, right? That's an example of peripheral tolerance in the periphery. If by any chance the central tolerance fail, nature have given you peripheral tolerance, right? The peripheral tolerance is basically absent of those co-stimulatory receptor, and as the co-stimulatory receptor is absent, in that way your cells are going to identify the T cells that they are here to kill me. So they are going to tell the T cells to sleep. I have recognized you, right? It's a statue kind of game, right? In the childhood, we used to play the game statue, right? So the kidneys are going to tell your T cell to statue there, right? To sleep, energy, right? That's all. Because I have recognized you. I do not have B7. You can't kill me, right? You have failed that process. So in autoimmune disease, we both have central and peripheral tolerance impaired. Okay. In autoimmune disease, I just already told you, it's a combination of a lot of things, not only central and peripheral tolerance. Genetic factors, environmental factors, a lot of things, right? So you cannot only blame these two things, right? It's a collection of thousands of features, right? Female, okay? Yes, but yes, that's obvious that we can have loss of both central and peripheral tolerance. Is the concept of energy clear, Dr. Nimra, and everyone else?
Yes, sir.
Hello? Okay. No, Doctor, no, no problem. Okay. Is it clear? Okay. So okay, just connected. Shall I repeat it? Hello?
Yes, sir. One time, please.
Okay. 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 So for that, you have to just make a story in your brain, right? What was your negative selection? Okay. No, no, you don't have to watch the recordings. I'm here. I have to repeat it again. No problem, right? So let's just make an interesting story before doing that. Okay. It's a good story. You should just remember it. Okay. So you have your thymus. In our thymus, you are having positive selection. What was your positive selection? In positive selection, MHC1 is going to interact with CD8 positive T cells. If they have good interaction, we are going to let them survive because we need strong interaction in order for for the CD8 positive to function with MHC1. We need a strong interaction for that, right? Okay. Hello.
Yes, sir.
Yes.
But we do not want T cell, we do not want T cells to have good love or interaction with our own body tissues part, right? So in the negative selection, basically we were bringing some tissue antigens, and those T cells who were showing love or attraction towards our own body parts, you were killing them. And that's really good for our body because we do not want T cells to interact with our antigen, our own body component, like it can be liver, kidney, because the problem with that is in the future, these T cells can undergo by type 4 hypersensitivity that can kill our own body parts, right? So negative selection was really important in order to eliminate all of those T cells which are going to in future interact with your own body parts. Is it cleared? Hello? Hello?
Yes.
Yes.
So negative selection was basically your central tolerance. Central tolerance. Central tolerance mean that we nature have given us this negative selection mechanism in order to eradicate all of those T cells which in future are going to kill us, which are going to cause autoimmunity, right? But nature also have given us peripheral tolerance as well. What if by any chance some of the T cells just did not undergo negative selection, we did not kill them? What if they leak into our blood? What if they are reactive against, I'm just giving you an example, against our kidney, and they leak into the blood? What would happen then? They would just come. Okay, for the T cells to function, we know that we have two stimulatory receptors. First of all, let's take an example of CD4. Okay, we were just using an example of CD4. How do CD4 get activated? We know that MHC2 is going to interact with the T cell receptor, but then we are going to be having a co-stimulatory receptor as well. What was the co-stimulatory receptor? That was B7 and CD28, right? And once both of them interact, then you are going to be having T cells coming into play, performing its activity. Am I right? Hello?
Yes, sir. Yes.
Yes.
But the B7 is present on antigen presenting cells. B7 is present on antigen presenting cell. So whenever the T cells leak out of your central tolerance, negative selection, they, let's suppose, enter into your bloodstream, they enter into the kidney and it start destroying your kidney. So it means that it still need two receptors to interact, right? It need T cell receptor, it need MHC2, right? It need T cell receptor, but it also need B7 and 28 receptor to interact with the kidneys, cells, and undergo its, its destruction process, right? Am I right? Hello?
Yes.
But the kidneys are not antigen presenting cells. It means they do not have B7, right? They do not have B7. So as they do not have that extra receptor, that so the T cells can never get activated. So the T cells are going to sleep there, right? Okay, the kidney cells are going to tell them to stretch you. I have caught you. I do not have that receptor. You cannot kill me. So nature have given us peripheral tolerance as well. That's an example of peripheral tolerance, which nature have given to us in order to avoid autoimmunity, right? One is central, there is peripheral, right? Is it clear? So energy is that sleeping of T cells without having interaction with B7. T cells are going to sleep there. That's energy, right? Hello?
So,
Okay. Okay. So let's just discuss our last topic for today. That is cytokines, right? Cytokines. So okay. So let's discuss interleukin one. And okay, the cytokines, okay, or the interleukins being released by your macrophages, by T cells, by Th1 cells, okay, and Th2 cells. We're going to be doing that, okay. So the one released by macrophages are interleukin 1. What are the function of interleukin 1? They cause fever. You know that, right? What else? They would increase the adhesion molecules. As I already told you, adhesion molecules are really important for the neutrophils to get into the site of infection. Do you guys remember that? Hello? Hello?
Yes, yes.
Okay. So adhesion molecules are really important for the neutrophils to get into the site of infection. Like we were having a process of margination, we were having a process of transmigration by those, PCAM, ECAM, right? The P selectin, E selectin, those were really important. So the expression of these P and E selectins are going to be increased by interleukin 1. Keep that in mind, okay? Okay. It's also going to increase the osteoclast activating factor, right? Really important. Interleukin 6. Interleukin 6 is basically going to release acute phase proteins, right? Acute phase reactants. When do we get that? Whenever you have chronic inflammation, the liver is going to make acute phase reactants. And one of it was hepcidin, if you guys remembered, in, which anemia? We discussed that. Hepcidin.
Anemia of
anemia,
chronic
Question
disease.
was
Anemia of
chronic
chronic
disease,
disease.
anemia of chronic disease.
chronic disease.
Perfect. Okay, so interleukin 6 makes acute phase reactants. It tends to release acute phase reactants from your liver, right? The other one is tumor necrosis factor alpha. That's really important. So if you remember, whenever we were having acute inflammation, the DAMPs and PAMPs, toll-like receptor being recognizing them, making NFK beta, it was just basically giving us three interleukins, one, interleukin 6, and TNF alpha. TNF alpha is really important in vascular leak. So in any kind of septic shock, we are having extreme vasodilation. That vasodilation is going to be due to TNF alpha, really important, right? Because it increases the vascular permeability, right? 8 to interleukin 1, 6 alpha that mediate fever and sepsis, right? So in the sepsis, the fever is going to be given by interleukin 1. Acute phase reactant 6 is also going to increase the fever and as well as the TNF alpha, which was basically leading to that vasodilation, right? TNF alpha maintains the granulomas. No, do not form the granulomas, right? Just keep that thing in mind. How does the granuloma form? We know that it's basically going to be your macrophages, Th1
Interferon
response,
gamma.
interferon
Long
gamma,
game.
right? Interferon gamma coming from your Th1 cells, right? But to maintain the granuloma, we need this TNF alpha, right? Cause cachexia in malignancy. What is cachexia? Thin individual with, with less, you know, less what? Fats and proteins, right?
Muscle
Muscles.
mass.
Yeah,
That's
muscle
cachexia,
wasting.
Muscle
right?
mass, muscle
Muscle.
wasting also.
Muscle wasting, yes. Interleukin 8, important for attracting your neutrophils, really important. Okay. Interleukin 12, we know that macrophages dump of interleukin 12 to activate your Th1 pathway, right? Th1 pathway, once activated, it's going to make Th1 is going to make interferon gamma being released on macrophages. Macrophages again are going to make interleukin 12, and a vicious cycle is going to be, made, which is going to, increase the formation of macrophages and granuloma, right? So, in order to get that Th1 response, we need interleukin 12. In order to get Th2 response, we need interleukin 4. Remember? Being made by your B cells, right? Hello?
Yes, sir.
Hello. Okay, so
Yes, sir. Yes,
interleukin
sir.
2. Interleukin 2. We know interleukin 2 in detail. We just discussed that in our entire pharmacology, right?
Cytokine,
Calcineurin,
kallikrein.
NFAT. Yes, calcineurin, NFAT, making interleukin 2, autocrine, paracrine, and endocrine effect, increasing mTOR receptor, right? mTOR making T cell proliferation. So T cells are basically interleukin 2 is important for the growth of your helpers, cytotoxic regulatory T cells, as well as natural killer cells, right? Interleukin 3, really important, GM-CSF, acting on bone marrow to increase the expression of eosinophil, basophil neutrophils, the granulocyte, right? So we discussed that we have our myeloid lineage and we have our lymphoid lineage, right? In the myeloid lineage, basically we are having the granulocytes, if you remember, right? Hello?
Yes, sir.
Okay, then we have interferon gamma. We discussed that it's going to be made by your Th1 cells. Once interferon gamma is released, they're going to act on your macrophages. They're going to release more interleukin 2, again acting on the same Th1, releasing more interferon gamma. Cycle is going to be made. Okay, one of your U world MCQ, for example, if you do not have interleukin 12 receptor, what's going to be the treatment option for those individuals if you do not have interleukin 12 receptor? Yes.
Supplements interferon gamma.
Yes, just give them interferon gamma because interleukin 12 in the end is going to give you interferon gammas, right? Okay, then TH2. Okay, TH2 basically make interleukin 4. Interleukin 4 is really important. In order to get that TH2 response, we need interleukin 4, right? We discussed that. So it's going to promote the B cell, right? And it's further going to increase the class switching as well in order to get, antibodies apart from IgM. Interleukin 5, really important. They're going to attract two things, right? IgA and eosinophils. IgA, eosinophils, one of your U world question. They're going to ask you the eosinophilia is basically going to be which interleukin? That's interleukin 5. Interleukin 10 is an anti-inflammatory. TGF beta and interleukin 10 both are anti-inflammatory, right? So in order to get, in order to avoid the exaggerated activation of your uh, you know, of your T cells or of your immune cells, you have interleukin 10. Interleukin 10 basically decreases the expression of both of your, MSC2 on your that would just decrease both of your CD8 positive and CD4 positive T cells. So they are anti-inflammatory, right? Then you have interleukin 13, which would promote IgE production by the B cells. Where do we have IgE? And a lot of reactions which we have discussed. Okay. So that was all for today's session. Okay, 7, 8, 9. So it was a 2 hour long session. So okay. So these were the topics which we discussed. Hope so you guys enjoyed. And that was all. Okay. Will we revise the immunodeficiency? So I just gave you 5 options, right? Okay, we can just schedule it on some other day. Okay, but for today we just okay, blood transfusion reaction. Okay, we can just schedule both of them to till tomorrow, right? Now just get ready for your okay, what about Dr. Moss for hematology? So Dr. Moss, I think, okay, so we can just continue with hematology tomorrow. If Dr. Moss is there, you can just attend the session, but I'm having daily constant session at this time. So whatever is left, I'm gonna do that in hematology. No worries, okay? Okay.
Thank you.
Okay. So today I'm also going to share my schedule, my availability schedule, and I'm also going to, share the entire roadmap again that what we are going to do in our next months and our next 2 months. So get ready for that as well, and start do revision for your assessment because after 2 to 3 hours I'm going to activate the assessment. Let me just make that as well. Okay. Thank you so much. Hope so you guys enjoyed session with me. Thank you.
Well,
Thank you.
thank you.
So nice.
Thank you. Thank you.
Okay.
Okay.